Very, very good afternoon to all of you. My name is Frank Njenga, and I am your host, if you like, moderator. And we have a very interesting panel of experts who will be taking us through the subject in hand, which is the challenges of reopening in the face of stigma associated with COVID-19. Oh, I see Dr. Mungangi has joined us. Thank you very much.
Yes.
Thank you, Doc.
Hello,
Oh,
Dr. Yu. Hello,
Doc.
Dr. Yu.
Oh, nice. We've been told that you might be a little late, but this is perfect timing. Welcome. And this is a good time. What I'll do is I will kind of say something about the panel that we have, just so that those who are attending can have a good idea of the weight of the thoughts and opinions that are about to be presented to us. And I will introduce them in the order that they will be speaking. The first one is an old friend of mine, Professor Lukoye Atwoli, who teaches at Moi University. He's also got an appointment at Harvard University, and who recently completed his PhD at Cape Town University. More recently, I think he will become, no, soon he'll become our president in the Kenya Medical Association. That's my prayer. But for the time being, he's the Secretary General of the Association of Psychiatrists in the entire continent. A very exposed man who knows a lot. Welcome to this forum. And then we have Maggie. Maggie Ireri is a distinguished researcher in our country. She is an award-winning personality in the field of research and has the unique capacity of transforming data into insights that lead on to action. I've known Maggie for many years, and I know because I have seen it, her presentation this afternoon is mind-boggling and will, in my view, help us a great deal in whatever it is that we will be headed. Our speaker after that is Dr. Mwangangi. Dr. Mwangangi, I have met her relatively recently, but I think it's true to say that Dr. Mwangangi has now become a household name. She brings on a regular basis calm, informative, and reliable information from our government. And if I'm to believe what I'm told by my colleagues, which actually I do believe that, she really does give us comfort that the Ministry of Health has a great future for all of us. And I can see panelists there nodding. We really appreciate the work you're doing, Dr. Mwangangi, and you
Thank you.
really inspire a great of confidence in us. She's a medical doctor, and she is actually interesting because she put the stethoscope down for a little while and holds a master's degree in health economics and policy from Australia. And she's also advised technically the Ministry of Health. So she is a highly distinguished person. Joe Ageo is an old friend of mine. Joe is a journalist. He worked for the biggest media service in Kenya, the Royal Media Services Group, which has 14 radio stations and 2 TV stations. We see him every Thursday night when he meets his gang. I hope we'll see him again tonight, Joe. Perhaps not, well, surprisingly, actually, he holds a master's degree in environmental governance from the University of Manchester and has a degree in agribusiness from Egerton University. Ladies and gentlemen, if you could, I'd ask you to clap for this very distinguished panel that is before us. Now, stigma is something that Professor Atwoli will be discussing with us from psychiatric, from mental health perspective, and I will therefore not do what I was asked to do, which is to talk about it. So without much by way of further ado, I will now welcome Professor Lukoya Twoli to do his presentation. You have 8 minutes, Professor.
Thank you very much, Frank. And I thank everyone. I thank the panelists for taking time to do this. And I also thank the audience who have made time to come and be with us this afternoon. Let me see. I hope my slides are now there. Yes.
Yeah.
So I would like to speak very quickly about stigma as it relates to COVID-19. But really, if you don't take anything else away from this discussion today, the message that I would like us to go away with is, can we all just be nice? You know, let's be nice to each other. Let's be nice to ourselves because there's too much nastiness out there already without anybody doing anything about it. So briefly, I can describe stigma as having 3 components. And the first component of stigma is huge. It's ignorance. And many people think being called ignorant is an insult, but it's just a statement of fact. Ignorance means lack of knowledge or information. And so as it relates to COVID, many people do not have sufficient knowledge or information about COVID-19. And yet, obviously, they want to present themselves as if they do. And this becomes an important pillar of stigma. As a result of lack of knowledge, there is prejudice. And this is negative attitudes and ideas about COVID-19 or about people infected or affected by COVID-19. And again, this is informed by ignorance. So you develop certain prejudices about these people. And the final thing is discrimination. So as a result of your ignorance and the prejudicial attitudes that you have about this group of people, you behave in a manner that segregates or separates you from those with COVID-19. There's a cycle. Stigma, proceeds in this cycle that first of all, you begin by, let me say, labeling somebody, onward to a COVID. Like I'm sure Mercy and her boss have often been labeled as what were COVID instead of the Ministry of Health, leadership. So they're labeled. And then there are stereotypes that are generated around these people. So they say somebody who has had COVID is dangerous. Somebody who has had COVID is very harmful. They can kill you, and so on and so on. So you start stereotyping them. And after doing that, then you justify the division between us and them. So you say, we are the good people. We are the safe people. These people with COVID or these people off COVID are the harmful people that we must, be away from. And when you divide people into groups of us versus them, us is usually the good people, the powerful people, the ones of higher social status, and them would then be reduced to being of a low social status one way or another. And as a result of that, then having identified them as a target and legitimized targeting them, we start discriminating against them. And, there's something called self-fulfilling prophecies. Once you start discriminating against people, then they acquire a label, and that label seems to justify the discrimination, and it goes through the cycle again and again. So this is a cycle of stigma, and with COVID-19, it's no different. Why do we stigmatize people and happenings around COVID-19? The most important reason is that it's a new thing. It's a new disease. We don't know much. So ignorance is there even among the experts. We don't know as much as we should know in order to advise you on what you need to do to protect yourself. The new and risky things usually cause fear. When something comes and you don't know how it will affect you, you don't know if it will kill you and so on, then it is legitimate to feel some degree of fear. It feels safer when we can link the fear that we are feeling to something or someone tangible outside of our immediate circle. So it feels safe when we say the danger is out there than when it is in here and we don't know exactly where it is. So we are always looking around for where can we legitimately locate that danger so that then we can either attack it or lock it up in there and we remain safe for the rest of our lives. And so a person who is infected or somehow affected by COVID-19 is a very easy target because this is, there it is. This person has that disease. that disease that we fear, that disease that is dangerous to us. So that's why we are afraid of this virus. What is the impact of stigma? The impact of stigma, as we are going to see in the coming presentations on what is happening out there in the community, is that we often increase ignorance and therefore increase stigma. So it's a cycle. When people stigmatize the illness, they avoid being tested because they don't want to be identified with it. They want to be in the us group, not with the them group that is supposed to be stigmatized. Those with symptoms or the illness will hide in order to avoid discrimination and other stigmatizing acts against them. And those who are infected will avoid seeking care also for fear of discrimination, because this, in the early days at least, people going to hospital would be discriminated against, would be treated differently from other patients and so on. And this served to propel the stigma against COVID-19 and the people who have it. And stigma inhibits healthy and protective behaviors, because doing these things link you to COVID-19. So if you're wearing a mask, people say, aha, you're wearing that because of COVID-19. If you're sanitizing, you're washing your hands, you're careful about not shaking hands. In areas where there's stigma, as you have seen in the US, for instance, people who wear masks are being looked at as, you guys are over-dramatizing the risk of COVID-19 and so on and so forth. So there's the stigma there. And then finally, stigma undermines the social cohesion and solidarity, leading to increased risk of spread of the virus. So once you stigmatize and you cause all these things that we have said, then people do not want to associate, people do not want to talk to each other, and this leads to increased risk of spread of this virus. How do we deal with stigma? You deal with the triad that I started with. You deal with ignorance by providing information that is accurate, that is timely, and that addresses issues as they emerge. You correct any misinformation that might be out there. You answer questions truthfully and as soon as possible, and you admit when you do not know. When you ask a question, and this probably applies a lot more to people who are involved in this pandemic, like Mercy and myself and others, there are things we don't know. So if somebody asks, we will say, listen, we don't know about that. Research is going on. When we find out, we'll come back to you and we'll tell you. As far as prejudice is concerned, we model the desired behavior. You don't just talk about it, but you model it. We should model a caring, humane, understanding, helping, and supporting behavior. And people will look at you as people in authority. And if you're doing those things, they would then be drawn and more likely to do those things. For discrimination, where possible, it should be outlawed. So if somebody is coming to hospital, you should outlaw and punish healthcare workers or people in authority who mistreat people with COVID-19. Otherwise, where it is not possible to outlaw it, then you should discourage it, make it a taboo. If somebody talks about it in a public gathering, you tell them that's inappropriate speech. You don't talk like that about fellow human beings. You uphold a rights-based approach in care and in social services. Adopt whole community approaches so that you don't just single out people with COVID-19 or affected with COVID-19 for assistance, but you help the entire community so that they're not separated from the rest of their people. And you assist people based on their need rather than based on their COVID-19 status or on their tribe or anything else. What you say and do matters. And so the language we should use should be people-first language. And I've seen a lot of COVID-19 suspects, that criminalizes almost having COVID-19. We should avoid associating the disease with any particular region or group. And I've seen people talking about the Wuhan virus and so on. We should talk about people being treated for or recovering from COVID-19 rather than these are cases of COVID-19 and these are victims of COVID-19, which really dehumanizes you. Avoid criminalizing language. So you talk about people who have contracted or contracting COVID-19 rather than people who are transmitting it, like they're carrying it and going to give it to other people. You should be factual when talking about risk. Avoid apocalyptic language like, all of you are going to die. So what will happen is that when there's only one survivor, people stop believing you because all of us have not died. Emphasize the positive, that the vast majority of those that get COVID-19 will recover without complication and often without displaying symptoms. And also emphasize the effectiveness of preventive measures and strategies like testing, contact tracing and so on, as well as sanitizing, washing hands, using masks and so on. So you can emphasize that so that people reduce risk without necessarily catastrophizing our communication. Above all, ladies and gentlemen, my message is just be a good human being and stigma will not be a problem. Treat everybody as a fellow human being, and when they have needs, address those needs according to how they are presented, and COVID-19 stigma will not be a problem. Thank you very much.
Whoa. In the real seminar in the old world, I think you'd be hearing standing applause for you. So well done, Munshi
Thank you.
Professor. Joe, what do you take home?
Joe is
you're
muted.
Joe. You're muted. We can't hear you. It's very unusual for a journalist not to be heard.
Yeah, that doesn't help. I mean, Prof always gets it done. I think that what I find interesting is that he has kind of answered a few questions that I will be raising. So that is an interesting order for things to happen. But he told me that it is the new normal. And so I think that to the extent that it not only raises some of the questions that arise on people's minds when you talk about stigma, I think he's done a good job in sort of proposing some ways in which we can begin to deal with this, considering that this is something that's going to be with us, as we are told, for a very long time.
Yeah.
I think, Joe, that's an important point, because sitting where you sit as editorial director in a big media house, you will have some impact on how moving forward fellow Kenyans look at each other. The reality is we generally agree that the worst is to come, but, and I think this is an important message, we are not bystanders. We can actually proactively do something to make that worst that is becoming less worst. Not English, but it's still a word. Okay.
Absolutely. Yeah. If I may interject, Frank.
Go on.
I think the days of, for instance, HIV, when I was in medical school in the 90s, there was a huge effort around giving information about HIV and how to protect yourself and so on and so forth. At some point, I think over 90% of adult Kenyans knew everything that there was to know about HIV and how to protect yourself. But people still engaged in risky behavior that continued to drive the HIV pandemic in the late 90s even. And there's one game changer. There was one thing that changed all that and changed people's behavior, and that was availability of an intervention, availability of treatment. So if I come and test you and you're positive, there's something we can do to ensure you remain healthy. So the message shifted away from scaring people to supportive, saying if you're tested and you're positive, there is something we can do to help you and so on. So I think for the lesson for COVID-19 is that the messaging should be in a similar way that, yes, the risk of getting it is there, but once you get it, we have done everything humanly possible to ensure you are comfortable and that you'll be safe. But do everything in your power to avoid getting it by doing this following slew of things. But in the unfortunate event that you get it, we are prepared and we will take care of you. That might drive behavior more than scaring people with things like death, in my view.
I think, Maggie, you didn't do complete justice to your study, because a deeper dive, seriously, a deeper dive into your own study actually, in a way, answers the point that the Prof is raising, which is that the people of Kenya actually know, 80% of them know that the majority of people who have the virus are actually symptomatic and live. Do you want to speak to that? Because I think that's a very important positive message that will not lead to carelessness. I saw that in your own study. Do you want to speak to that, Maggie?
Yeah, okay, so there was a chart which I've not presented, but I'll speak around it, because we asked some questions about beliefs about COVID. And one of the questions we asked was, do people who get COVID recover? And we have over almost 80% saying yes, people who do get COVID have a high probability of recovery. And also, there was also a question about, do you believe that social distancing can prevent the spread of COVID? And the answer was yes. So just summing up what you're saying, there's definitely high awareness about the disease. there's high awareness about the appropriate behavior. But my personal opinion, having looked at the data, is that now that we know what to do, I don't think we know how to treat people who have gotten the disease. I'm reminded of a friend who tested positive COVID, and when he was in hospital, he actually posted on social media, Twitter, and said, by the way, I have COVID and I'm in hospital. But he said consistently, he was being asked, why did you declare? And what he was trying to do, he was trying to say, it's real, please take care. And now that he's out of hospital, he's been calling people and saying, I am well. So I think we know what you're supposed to do, but I think the more examples we get of real life stories that people have recovered and they are okay and you can interact with them, I think that's the time we'll change the issue of stigma. And the last thing is that at the moment, only 8% know somebody close. Before 2 weeks ago, I did not know anyone. But now that I know, I'm actually planning to have coffee with the person next week. So I think the more experiences we get that are positive, I think that will definitely change the perception we're seeing in this survey.
Joe has been introduced already. Those who were not there when I introduced Joe, he's editorial director in the largest media outfit in the Republic, the Royal Media Services. Good. Proceed, Joe.
All right. Thank you very much, Dr. Njenga. One of the things you did quite say was the fact that we have reversed roles here. Actually, I'm more used to asking people questions. And so as I make my presentation, there's a high likelihood that I'll be asking more questions than answering them. But I do hope that you can understand that. So this quote, and I think that Professor Atwoli spoke very eloquently about this phase of stigma that we see everywhere. I mean, look at this was a certain person who was interviewed by SciDev, which is a science-based publication, and this captures what really we see many times in the neighborhoods and that sort of thing. And we hear these kinds of stories as journalists, and we've been attempting to do these stories. We have our own, for example, we have seen here in Kenya, this lady, for example. I mean, many of us who remember Brenda Cherotich, who was on TV. We interviewed her many times, and there was an interesting, if albeit sad, that as soon as she came out and said, I have recovered, and the Ministry of Health basically came out with her. That picture was taken in the boardroom of the Ministry of Health, actually. She was on TV and told her story. She was the first patient of COVID-19 that we know of in the country. And so what happened is that after that, there was a lot of conversation about her on social media, not very complimentary, I would say, people doubting, why you sick in the first place? Some people saying, why did you bring this thing to Kenya? And I have to say, she is a strong girl, but it is the kind of thing that we have seen many times. And I think we will have time to discuss her case specifically because she was the only patient, I think, that we have known about that came out and not a very positive story in terms of how people reacted. I do not know whether we have all the answers to why. But as Dr. Atwoli had indicated earlier, I think one of the things that are so different about this, one is that this is a new disease. So people know very little about it. And when people don't know things about a new situation, especially one that is dangerous, that is risky, then people tend to behave differently. As a journalist, the interest that we see that the public has in this story is massive. But at the same time, the consequences of getting it wrong then are massive, because if you give out the wrong information about something that is serious, you can cause harm. And one of the things as journalists we try to do is to do no harm. And that is therefore a challenging thing, because it is very easy to get something wrong when very little is known about it. Then the other thing is that the containment measures actually run counter to the inherent human relations. People like being relational. People like hugging each other. People like, eating together, having gatherings and that sort of thing. So there's a sense in which it has changed how things are done, so much so that even how we do our work has changed dramatically. And that has implications on how this is communicated about and how that message is received. So as journalists, we have many roles, and you could list 20 of them, but many people them, and then we inform people what is going. There is a function we call correlation, where you look at events as they happen in society. That's why we'll say, yesterday there were, this 307 new patients. We don't know how many there will be today. When we get the new figures, we will then relate them with what happened yesterday. So people get a perspective. We'll say, well, it's 307, but it is out of how many samples that were tested, and that gives people perspective. The third one, which is even more interesting, is there is a certain sense in which media people believe that there is a certain cultural transmission that happens when you see things. I have a 6-year-old who one time we were celebrating his birthday, and he said, "Get this party started." Now, people don't speak like that in Kenya, but he probably picked that from some other place. So we kind of influence societal norms as well, and that is important when you talk about behavior change. There's the usual one, education, entertainment, and that sort of thing, and that will have relevance as well when you're talking about messaging around this kind of situation. Now, the big question, which is where I think when we begin to talk about the role the media is playing or can play, is does it follow? In other words, is the media setting the agenda, or does the media follow a different agenda but that has been set by someone? Some people will say both, but that has implications on how effective, therefore, the media can be in the face, for example, of something like the COVID-19 pandemic, which is not only very technical when you start hearing about the terminologies that the experts would use, but also very little is known about. So the journalists, because they are not medical experts, they would tend to rely a lot on what they hear. And therefore, if language that is used around them by experts, by people who know, has certain elements that could propagate attitudes that could lead to stigma, then it is possible that the media may regurgitate or may just amplify some of those things that are said. So the problem of stigma, and Professor Atwoli spoke a lot about this, and I think it is fair to say that he is way more qualified than I can probably do. But there is a sense in which stigma is framed as this thing that is done to other people, and therefore there is very little focus on the people who are recipients of this repugnant behavior. In other words, the messaging tends to try and influence the behavior of the people who are either already propagating stigma or actually have the potential of doing that. What about the people who are already being stigmatized, the people who could be stigmatized? Is there messaging that goes their way? Where are they? And what does that then mean in terms of how effective we can be? The other thing is that there is discrimination. Someone said we could outlaw it. I think, Prof, it was, and that is great. Does that mean that people have changed how they think just because you tell them now you can no longer do this, they may comply? If you just tell people there's a curfew, you can't come out, does that mean that they truly know and believe that it is the right thing to do? That has implications on how people respond. There's also a question of people might change their attitudes about something, but it might not lead to behavioral change, as we have seen in this country from the survey that Maggie did, that a lot of people actually know, but they don't do. So that is a big question for us. Many of you will have seen representations of COVID-19, or indeed the novel coronavirus that causes it in some instances, as an enemy. Many governments have talked about this as the invisible enemy. This is l'ennemi invisible. I had that was in France. Around the world, that is almost like standard practice. How does that make people feel, and how are they likely to respond to people who are in any way associated with people who have had contact with this invisible enemy. We've had language about super spreaders, people who gave it to everybody else, that there is this one person who is responsible for giving the virus to a certain number of people. And that is what the question of war, the fight against this thing, the unseen enemy, and that sort of thing. We have been told this is a very contagious thing. All of us now know it can treat us very abnormally. Okay.
Maggie, do you have a comment?
Yes, so thank you, Joe, for that presentation. My comment would be, in this time of COVID, the media has definitely, in Kenya and across the world, been very instrumental in educating the population about COVID. However, I think one of the challenges with the media is the issue of fake news. I mean, there's been stories left, right, center, which could have presented some of the facts that were presented either by the Ministry of Health and so on. So maybe I would, now that Joe is back.
Yeah.
Joe, you can hear me?
Yeah, I can.
Yeah, so my question was, how is the media dealing with fake news during this period of COVID? We have people misrepresenting what has been given by the Ministry of Health, and how are you dealing with the issue of being the most credible source of information in terms of a news or a media house?
Well, good question. I mean, if you think about what is called media these days, I mean, there was a time that it was very clear what that meant. Right now, everybody is a media house. You can have your own YouTube channel, you can have your own Twitter handles and all of these social media platforms that can have actually a bigger impact than what we call traditional or legacy media, that is TV and newspapers. And what we try to do is to become that place where people go to refer when they want to know whether something has truly happened or whether it is indeed true. But it is almost impossible right now for any media house to police and try and correct every notion out there that might be on social media, because most of the conspiracy theories, most of the fake news, the infodemic that the WHO talked about is actually found on that space of social media, which is why a lot of the credible media houses try to play in that space as well. I mean, we run a very big social media presence that then helps to put things in perspective. And that is just about as much as we can do.